Welcome back and thanks for staying with us. You're still watching Rapid Dawn right here on Rapid Television. And of course, today on the big conversation, we're going to be having a conversation centered around something really interesting that every one of us should pay attention to. But first, my name is Victor. Okay.
And my name is Martha Alu. Welcome to the very final segment of Rapid Dawn for this beautiful morning. Yes, today's conversation is that it is very interesting and it's very important that we have talk about seeing the incidents that has followed suit in the last couple of days.
Very true. And of course, we're talking hypertension today. It's important that we pay attention to these. Hypertension, sometimes some other persons call it high blood pressure. It's one of the most serious health challenges today, not just in Nigeria, but of course in the world at large. And many times it's also called the silent killer. And it can develop without obvious symptoms, yet it significantly raises the risk of heart disease, stroke, and kidney failure. Globally, an estimated 1.28 billion adults live with hypertension, and over 10 million deaths each year are linked to its complications, according to the World Health Organization. Now, in Nigeria, the picture is just as concerning, as we see that studies show that about 30% of adults have high blood pressure, but less than 20% manage it effectively. Urban areas are particularly affected, driven by lifestyle factors such as poor diet, stress, obesity, and low physical activity. And that's why most of the times we always encourage you here to carry out some physical activity like exercise. But sadly, awareness and treatment remain low, meaning that many Nigerians live with hypertension without even knowing it. And that's the danger in it. And so today on the big conversation, we are joined by Dr. Onyinye Mbomson, the senior registrar in the Department of Community Medicine and Healthcare. And she's going to be here to help us understand the risk, the prevention strategies, and of course the practical steps Nigerians can take to protect themselves against this silent but deadly condition. Because it's quite sad knowing that high blood pressure doesn't always announce itself. And of course, this conversation, we believe, can save lots of lives out there. And let's begin the conversation. Dr. Onyinye, good morning, and thank you for joining us on the conversation this morning.
So
Okay.
I'm very happy to be here today.
Okay.
So bringing me to talk about this topic is actually one of the things we do. Talking about preventive care is what we actually do in community medicine department. So today we are going to talk about hypertension. He has already done a brief introduction, which is very important. A lot of us don't know about this. We see lots of people in the clinic saying a lot of things that sound weird to us because, looking at the jet age, we feel that a lot of people have knowledge about hypertension.
Right.
So I'll start by telling us what hypertension is. I don't know whether this will be an interactive section or something I have to go on. Okay, so we'll start by describing what hypertension is. Hypertension, like we all know, layman's word, high blood pressure. We have what we call the systolic and diastolic. So we have the systolic, which is the one on top and the one down. People say it's just numbers, but these numbers are dangerous. These numbers are silent killers that when you have it, anything can happen at any time. So hypertension is when your blood pressure, when measured, is above 140 over 80. Okay. It's a millimeter mercury. So when you check it and it's above that, you have to recheck. You have to make sure that you do a repeated check of your blood pressure to be sure that to certify that you have hypertension. Some of us will check our blood pressure, will say, we are stressed, I've slept, and then my blood pressure is okay, so I don't think I have hypertension. No, that's wrong. If you're stressed, there is a particular number we're expected to have. And if you rest and then you're stressed again and your BP is going up, it's hypertension until proven otherwise. So let's now talk about the common risk factors. There are people who are prone to have hypertension. We have the modifiable and non-modifiable.
Okay.
Modifiable being things that you can work on, things you can prevent, things you can control. But when you talk about non-modifiable, there is nothing you can do about this. And the two important non-modifiable is age and family history when you talk about genetics.
Okay.
And then the modifiable factors are things like what you eat, diet, exercise, let's just say lifestyle modalities. those are modifiable. So when you know that these ones are the ones that you can control and prevent, but the non-modifiable factors, there is nothing you can do about it. Okay, so why are we afraid of hypertension? To think of it, some people will say it's just numbers. Like one of my patients said 2 days ago, he said, but doctor, this is just numbers. I'm walking around, nothing is happening to me. It's numbers till you slump. It's numbers till you someone say, I saw him yesterday and today he's gone. So the numbers are not to be joked with. Okay, right. So there are a lot of things that are associated with this. The commonest is stroke. Stroke. You can also have renal damage. And this is one of the commonest problem we are having now. We have a lot of people that were always contributing money for dialysis, having kidney failure, and all that. And remember, once you have hypertension, because it's associated with renal damage, you are prone to have other co-infections. Some come down with diabetes. So at the end of the day, some people will say hypertension, okay, like you introduced, you said it's a silent killer. That's what it is. Because I could have high blood pressure and I'm moving around. Nothing is happening because at that time, my body can auto-regulate what is going on. But at the time, the engine breaks down. I'm tired. I can't keep helping you. And then you shut down. That's why you see some people that are having blood pressure of 220/180. You see the patient sitting directly in front of you, healthy, moving. And you say, God, this your case is a case of hypertensive urgency. And the patient says, but doctor, I walked from my house to the hospital. Because we don't understand what this entails. And this is one of the mistakes we make.
All right.
And how do we avoid this?
All right.
Is about doing.
Just hold on. Before we get on to that, you seem very passionate about the topic, and it's very important that people are aware as much as possible.
Yeah.
And yes, just as you have said it, my co-hosts have reiterated, the WHO calls it a silent killer, and for reasons which we have also highlighted. Because I mean, a person can be moving with hypertension, and they're not aware of it. In fact, statistics say that 30 to 38% of Nigerians live with hypertension, but only 40% of that group of people are not even aware that they have hypertension, which is very risky. But one thing I feel like we're not talking about is how this particular illness have moved from becoming an illness of the elderly to now that which affects young people, young professionals, even teenagers these days. They come down with hypertension. Please, can you tell us what is responsible for this shift in the age numbers that we see, between an illness that usually used to be considered that of the old to now being very, very popular among the young and the teenage population?
Okay, that's very simple. Okay, let's start with what I mentioned earlier. One of them now is diet.
Okay.
Now, the young people consume more of processed food, which is salty. We go for canned meals. We go for easy to make food. This food we are taking are the major risk to hypertension amongst the young age group. Another one is stress and anxiety. We are stressed. Some people don't rest. We're always working because we are trying to make ends meet. And at the end of the day, we forget to take care of ourselves. We forget to rest. Like I was talking to some group of people the other day, and they said exercising is not for people that are young because they are still agile. That's not true. That's not true. Exercise is for everybody. And these factors have caused the increase in the number of young people with hypertension. But the major cause, like I said, is diet, processed meal, Indomie generation. So that's what I call them. Thank you very much.
So let's talk about the symptoms briefly.
Yeah, before we go to the symptoms, she made mention of the fact that it's an illness where people have, imagine we're supposed to have diastolic and systolic, 180 over 20, 120 over 80 rather, is what is, yes, 120 over 80 is what is meant to be. But someone is having about 200 over 180, yet the person does not present any symptoms at all.
Exactly.
Why does this happen to the body? Because we know that illnesses like malaria, typhoid, you know, HIV and AIDS, hepatitis, these illnesses have symptoms that are associated with them. So once you come down with any of the symptoms, you suspect what it is, and then you go to see a doctor for further examination and then diagnosis eventually. So, but why is it different with hypertension?
Okay, thank you so much for asking this question. But I want to shock you before I answer the question. You said most illnesses, you mentioned malaria, HIV, and so on, that they present with symptoms. But I want to tell you something. HIV can be there for 10 years without symptoms.
Oh, really?
So most of the time is accidental findings. Maybe you're doing premarital screening. All this depends on your body system. Like I mentioned earlier, I said the body is working. It's like you have an engine. You come and turn it on, it's working. That engine gets tired one day and it won't be able to do that function again. Now, when my blood pressure is rising, my body is auto-regulating it. My body is stepping it like, oh, I can take care of this. I can shield this. I'm fine. At a time, you're moving with 200 over 180. You see yourself having this particular number for like a month too. My dear, in the third month, your body is saying, I can't help you anymore. And then those symptoms start showing. For example, someone that lives a sedentary lifestyle, having these symptoms comes up faster than someone who doesn't. Now, what are these symptoms we are talking about? Headache. Now, are you going to tell me that people that have malaria don't have headache? They have headache. But what is striking about hypertensive headache? Some people describe it as occipital headache. That's at the back of your head. It's strobing in nature. But when it becomes strobing, that means the cardiovascular system, the cerebrovascular system is now being affected. And that's when you start talking about imminent stroke. So hypertension at its own does not have any sequence when it comes to symptoms. Some people are symptomless. We call them asymptomatic hypertensive patients. We have the symptomatic ones that can come down with headache. They can come down with nausea. Now, you're going to tell me you don't have nausea in malaria. People that have malaria still have nausea. So you can come down with vomiting. People come down with chest pain. Some complain of back pain. Some complain of generalized body weakness. Some have symptoms like breathlessness. Doctor, as I'm walking, I get tired easily. This doesn't happen to me before. So these are the symptoms that you could see, and then you think of it. Now there's another one. There is now a new symptom that we now notice in the hospital. We have bilateral limb swelling. Someone's limb is swelling and they said it's something that is done in the village. It's not it, it's hypertension. But at that point, your kidney is now involved. In some issues, the kidneys are not involved, but the heart is no longer able to pump blood as it used to do before. The heart is tired. So the blood that is supposed to be pumped does what? Goes down and goes down there to rest. So in some cases, once we come across someone with bilateral limb swelling, we check your BP.
All right, Doctor,
very important. Thank you very much.
As much as you mentioned to us that there are no symptoms as it is, but again, there could be, are there warning signs? Because when someone has gotten to that point where the liver, the kidney is not being affected, you know, it means it has gotten to a very, very extreme case as it is. But are there warning signs as well that you could look out for, basically?
Exactly. This is a very wonderful question. One of the warning signs is thrombin occipital headache that
Okay.
is persistent. It doesn't go away even with Panadol. It doesn't go away even with ibuprofen. No matter the amount of analgesic you take, that headache stays there. Blurring of vision, very important. Your vision becomes blurry. Some people will say, doctor, when I'm walking, it's as if I'm dizzy. It's as if I can't see well. Number 2 warning sign. Another warning sign is palpitation. Persistent palpitations. It doesn't stop. Your heart keeps beating and you are aware of it. Like I'm sitting now, my heart is beating. And I'm sure you too, your hearts are beating. But you're fine.
Right.
But if it's the one of the warning signs, like I said, is the heart will be beating and you will be aware of it. Persistent palpitation. Like I'm sitting here now, my heart will be beating and I'm feeling it that it is beating. I will be on ease. I don't know whether I'm clear. So these three are very important warning signs that when you have them, you have to rush. But the first that usually presents is the throbbing occipital headache. Okay. Thank you very much.
All right. I want to ask, are there noticeable differences between hypertension in men and hypertension in women, particularly in Nigeria, especially considering pregnancy-related hypertension and hormonal factors? Is there like a very noticeable difference, if there is at all?
Nothing much, but like you said, when it comes to hypertension in pregnancy, there's actually a particular stage in the pregnancy, in the level, we call it the gestational age. There's a particular gestational age that the blood pressure starts rising. And funny enough, 6 weeks after birth, the hypertension goes away. And that's why we call it pregnancy-induced hypertension. And these are caused by hormonal flares. And most of the time, you can't tell what happens to you. Okay? Some people said it's genetic, and some people say it has to do with your hormonal balance during that time, at the peak of your pregnancy. So at the end of the day, the only striking difference is pregnancy and non-pregnant stage. For male and female, it's the same thing. But the only thing that shifts the female away is that which is associated with pregnancy. Otherwise, symptoms present alike. Thank you very much.
Welcome back. You're still watching Rapid Done right here on Rapid Television. Of course, we've been having a conversation centered around hypertension with our guest, Dr. Onyinye Mbomson, and she is a senior registrar at the Department of Community Medicine and Primary Health. Once again, Dr. Onyinye, thank you for being here with us. So
I was asking that, you know, we talked about gestational illnesses in pregnant women. We talked about hypertension. We talked about diabetes. We have seen cerebral palsy. Now, we are saying in cases where that conditions like this do not reverse even after pregnancy, are you handling them in the same way? How do you go about it, particularly for hypertension, since that's the case study?
Okay, so if the hypertension persists after pregnancy, you manage them in the same way as you manage hypertension. That means the person has developed chronic hypertension. So one of the cases here is that, one, is either it was misdiagnosed pre-pregnancy state, or there is a family history of hypertension which the pregnancy has made the woman to go into. I don't know whether I'm clear. So pregnancy has made the hypertension to be seen. But before pregnancy, it wasn't there. Remember, pregnancy comes with fluid retention. Pregnancy comes with overworking of the heart. So these alone can actually push someone who was pre-hypertensive to hypertension. I don't know whether I'm clear. Is there any confusion?
Yeah. No, not at all. Okay. You say the pregnancy just makes it obvious. Yeah. Yes.
Exactly. Because like I said, pregnancy comes with fluid retention. It comes with hormonal imbalance. Remember, when you have a high cholesterol level,
Okay.
it pushes to hypertension. That's another one risk factor I forgot. Okay, anyway, when we talk about diet, is one of them, high cholesterol, because it's from your diet that that you will start having high
High
cholesterol.
cholesterol.
Exactly. So when pregnancy comes in, remember the hormones are steroids. They become high.
Okay.
Fluid retention is high. The blood volume is high. The heart works a lot. These alone can push someone who wasn't hypertensive to develop hypertension. But the good thing is, if it's pregnancy induced, like I said, within 6 weeks after the pregnancy, the woman gets better. But if there was underlying genetic factors, underlying misdiagnosed event, that hypertension, prolongs, and then we now term it chronic hypertension. It's no longer pregnancy-induced hypertension, and they are being managed just like hypertensive patients. Thank you very much.
All right.
All right. Now we're talking about management, and of course, as it is, once someone is being
Okay.
diagnosed by hypertension, once someone is being diagnosed of having hypertension, what are the typical treatment options that are available?
Okay. Anyway, this is just because it's a TV radio talk show. Normally, to be honest, we don't like sharing management of hypertension to the general public, because
The drugs
once you
can
do
be
that, you see
abused.
some people jotting down the
And
drugs, not knowing.
self-medicating.
Exactly.
Exactly.
Exactly. Like there was a patient I saw one time. He said someone was talking about hypertension, and they mentioned amlodipine. They mentioned what's that again? Lisinopril.
Yeah.
Now those drugs, they are not okay for that particular patient, and he was taking them. So instead of doing the work he needs to do, he was complicating it.
Oh.
Because management is what unique to every
Everyone.
patient. For example, if a patient has diabetes with hypertension, I'm not going to manage you the same way I'm managing someone who has solely hypertension.
Very true.
I don't know whether you understand.
Yeah, that makes
So
sense.
some drugs, exactly. So some drugs that I will give that person that has only hypertension won't be same with someone with diabetes. Okay. But anyway, just to summarize it, in the management, one, we have the investigations. Why are we doing these investigations? And these investigations are centered on the kidney. Why are we doing this? Because most of these drugs are metabolized by the kidney. So we need to know the function of your kidney. So we call it renal function test,
Yeah.
where we do the serum electrolyte, urea, and creatinine. These are the components of the kidney. These elements help us to know how much the kidney is functioning.
Right.
It helps us to detect the drug that you can take,
Okay.
the dosage.
Okay. All right.
Is it making sense?
Yes,
So
it does.
that's number one, very important. Yeah.
Okay.
This whole idea of self-medication is one thing that, I mean, advocacy needs to go out
very much.
on out there about that. I know that the government has tried its best on the crackdown of these illegal chemists and pharmacies and all of
Yeah.
that. Yes, but let's
Yeah.
talk about myths and misconceptions. Now, the reason
Okay.
I have heard people say countless times that once you start taking hypertension drugs, you will never stop again. And some people say that. Other people are of the opinion that the drugs even
Okay.
make it even worse, or makes the condition even worse. You know, so many things a lot of people have said about it, because they are drugs, they are routine drugs that some, depending on the condition they find themselves, have to take on a daily basis just to be able to maintain or sustain their blood pressure, or as prescribed by the doctor. But tell us about these myths and misconceptions.
Okay, so let me say something here. Once you start the medication, like you said, it's for life. One of the misconceptions is that once the BP is okay, you stop taking your medication. That's one thing we see a lot in the clinic. But the truth of the matter is this. The reason the BP is low or is at the manageable level, is because of the drugs. The drugs are working. And once you stop the medication, the BP will rise again. Now, the drugs do not harm you in any way.
No side effects?
They do not harm you. We have side effects, but the side effects, it doesn't mean the side effects are harming you in a way that can be managed. For example, let's take, for instance, the ACE inhibitors, that's the lisinopril. They come up with dry cough. But once you stop taking the medication, the dry cough goes away. That dry cough doesn't mean that the dry cough you're having doesn't mean it has any effect on your body. It's just because the drug itself causes dryness. It causes dehydration.
But you have said now that when you start taking the drugs, it is for life. And we are talking about, we just made mention of the risk factors, or the, how do they call it? Yeah. The side effects, right?
Exactly.
And you have said it's dry cough. Once you stop taking the drug, the dry cough goes. So how can we reconcile this?
Oh, yeah, let me come back. You know, you didn't let me land.
Okay.
This is the reason when you have hypertension, we call it routine medical checkup. Okay. Routine medical visit. Now, when you tell us that this particular drug, you see why I talk about the self-medication. When you tell us that this particular drug affects you, we go to the ARBs. There is an alternative. Okay. We leave the SCEs and give you the ARBs. So at the end of the day, that's why it's always good to see a doctor. Absolutely. You talk to the doctor. For example, if I meet a patient who I know that has pneumonia or tuberculosis, I won't go giving ACE inhibitors. Am I making sense? Yeah, I will go to the alternative. So that's how it is. So for all the drugs, that's why I said the treatment is unique to every patient. That's why I said the management of hypertension is unique to every patient. So it tells the group of medication you will take, and you have to take it for life. That's what we are saying. But you have to see your doctor.
So
you have to let your doctor. There is no cure to hypertension. No cure to hypertension. Don't be deceived. Some people will say, I was taking, just take for instance, last month when I was at the village, my neighbor had stroke.
Okay.
The kids were surprised. They said, doc, but my mom was taking this medication and the BP was actually okay. You see the problem. And when it came so bad. Wow. She now has stroke. She can talk, she can walk, she can do anything.
Was it because she stopped taking the medication?
Exactly, she stopped taking the medication.
So the symptoms and this is one of the back once you stop taking the medication.
Exactly. Okay. Because what is making you to stay is the medications.
So it has to be managed. You have to continually manage it.
Well, exactly. That's why it's one of the most common chronic diseases. When we call it chronic, we never said one of the cure diseases. We said chronic is for life, just like diabetes. Yeah.
Well, let's talk about awareness as it is, because a lot of persons still need to be aware of all of this. As someone who also works with primary care, are there effective programs that you run, to ensure that the public are aware of hypertension, what they need to do, how to prevent it, and eventually manage it if they're being diagnosed of it? Are there awareness programs that is being run, by primary care
thank you so much. All right, thank you so much for your question. Yes, we do. Like yesterday, it was part of the reasons I wasn't able to meet up, because I was preparing the same health talk on health, hypertension and diabetes. But usually we go more to the remote areas. People we know that don't have these internet services. We go there to meet them at churches, at the primary health care centers, as well as general hospitals. So we actually do that. And we're happy that a lot of people, I don't know, but greater percentage were aware of hypertension when I spoke to them about it yesterday. But we haven't been able to cover, large number of people anyways, but we're trying to work on people that don't have
access to. Are you with us, Dr. Onyinye? The network seemed to be not so on our side today. Okay, Dr. Onyinye, it's good to have you join us.
All right.
Go ahead with the question.
Can you hear me?
Yet, loud and
Okay.
clear.
So I was going to ask you one other question, which is the
Okay.
affordability and accessibility of the drugs. Because we have made mention of
Okay.
the fact that most people don't know. And some people,
Okay.
even though they know, have not acted on it because they'll say, oh, there's this herb that can help. This is a cheaper way to treat it. This is an
Ooh.
easier way to go about it, you know. And because of that, they don't go to receive treatment, right? So if we are trying to combat ignorance, if we're trying to combat lack of proper care for yourself as an
Yeah.
individual, what are we doing? Because I see you are in the primary health care. What are you doing to
Yeah.
make sure that the drugs are accessible?
And
Not only
affordable.
are they accessible, affordable also for people who happen to come there for treatment.
Okay, thank you very much. Actually, we run medical outreach program. We usually do it twice a year, where
Okay.
we distribute hypertensive medications, especially the ones that we know that have minimal side effects. Okay, and these drugs, they are affordable. Because I could remember when I was purchasing a pack, I think a pack cost I think 1,000 plus or so. And I'm like, so if it's so, why are they not taking the medication? And that 1,000 plus will last you for 30 days because it's taken every day. Okay. So when we're doing outreach, we'll try to go to those drugs that are affordable. Sometimes why we do this is for you to have a continuity. But during the outreach, we still tell them that please, when you're taking these medications and you experience anything, come back to the doctor at that particular primary health care center to come and complain to him. It helps us when we are coming back for the next outreach. We now work on the drugs we could, put into the drugs that we bring in during the period, because it's usually hypertension we try to reach out to. Yes.
Okay. That's amazing. Thank you so much.
All right, thank
You're
you so much.
welcome.
Thank you so much, Dr. Onyinye, for being here with us on the conversation. But this is the much that we can take today. Thank you so
Absolutely.
much. We
So
do appreciate you and wish you the very best
It's all right.
beautiful day today. Thank
have
you.
an
Thank you
amazing
for
day
having
ahead.
me.
Thank you.
You too. Thank you so much.
Thank
All
you very
right.
much.
But before calling
Okay,
to wrap,
bye.
it's just important as well that we remind you, go check your blood pressure today. This conversation was had so that we can be aware of how we feel as individuals. And one of the best ways for you to do that right now is to take action and check your blood pressure so you get to know exactly how you are doing. But of course, that being said, this is all we're going to take on the conversation this morning. Do remember that you can follow us across all our social media pages across our platforms at Rapid TV. And you can get to rewatch all our episodes on our YouTube platform, which is at Official Rapid TV. And wherever you are in the world, you can watch us live using our website, www.arabianradiotv.com. My name is Victor. Okay.
And my name is Martha Alu. Before we go, I would also remind you to know your number.
Right.
It's very important.
Very
Have an
important.
amazing day ahead.
We'll see you tomorrow.